ERA 223 was an 800 or so patient trial. It was reported out by Dr. Matt Smith at ESMO. I unfortunately was not able to go to Europe for that meeting, but I've seen the slides and shared the data with some of my friends. And the paper apparently is in press or about to be published. And the top line result is that there was no survival advantage for adding abiraterone to radium-223. The median survival was essentially the same. There was, however, a signal that more patients had fractures when given abiraterone simultaneously with prednisone and radium. That signal of fracture was reduced in patients who were getting bone hardening agents, such as either denosumab or zoledronic acid. It still showed a differential higher fracture rate in the patients given abiraterone and radium-223. I believe it was relatively minor, but nonetheless it led the EMA, which is the European Medicine something or other, I don't know what EMA stands for, and the Health Canada to recommend against giving abiraterone and radium-223. To me, it's not a game changer. In this particular patient, I've already given him abiraterone. He's progressed on it, and so now I want to control the bone metastases. Now, a bigger question is whether or not there are other agents that could enhance the radium-223. As I mentioned earlier, Sipuleucel LT would be something that I would definitely give. And there is a study underway called PEACE, PEACE3, in which patients are going to be randomized to radium or radium with enzalutamide. That would be interesting because, as I mentioned earlier, the option for this patient would be enzalutamide. That would be one of the options. It should go very well with radium, and for certain patients, it would be fine to be able to do. There's no reason not to do it. So some of us will give, in this particular situation, enzalutamide and radium, even though we don't have clinical trial data yet to support that position. What I would remind everyone is that radium-223 is not a pain drug. It is not given for control of pain. It's given to improve survival. That is the reason the FDA approved the drug. The FDA looked at Alsimca, the randomized trial of radium versus placebo, and concluded that survival was prolonged by the use of radium-223 when given to 6 doses. Radium-223 also met a series of secondary endpoints, including reduction in the use of opioids, reduction in the rate of hospitalizations, reduction in the rate of symptomatic skeletal events, or SSE, and overall improvement in quality of life when measured in a variety of ways. So it makes me surprised when more of my colleagues do not use radium-223. It has a survival advantage and a variety of other very important advantages, one of which is control of fractures and control of pain. And we as physicians don't always do a great job controlling opioid and pain and fractures, but you have to give the drug to get that benefit. And if you don't give the drug, you don't get the benefit. The challenge to us as physicians caring for prostate cancer patients is that there are increasing number of options. As I mentioned, integrating these options, including chemotherapy and radium, is a challenge. For example, we have a study underway called DORA, D-O-R-A. That study is run by Michael Morris from Memorial Sloan Kettering. There will be a number of sites. Many sites in the Netherlands will be joining the trial, and it will be a randomized trial of chemotherapy, docetaxel, versus chemotherapy with a lower dose of radium every 6 weeks, and chemotherapy at a slightly lower dose of 60 milligrams per meter squared instead of 75 milligrams per meter squared. So that study is just about to open, and it will give us, again, an idea as to whether you can put these agents together. We already know that Sipuleucel LT and radium can be given together. We now have the ERA or ERA-223 suggesting that abiraterone and radium are not necessarily beneficial together. They're not particularly harmful except in the fracture rate. And we're waiting on piece 3 to see whether the enzalutamide and radium-223 will improve overall survival.